It all started with a whisper, a rumor of money changing hands, not for better care, but for less. UnitedHealth Group, a giant in the American healthcare landscape, was quietly paying nursing homes. These weren't just any payments, they were bonuses, secret bonuses, the kind of financial incentives that make people sit up and pay attention, or in this case make them look the other way. The goal was simple: keep elderly residents out of hospitals. Fewer hospital visits meant lower costs for UnitedHealth. Lower costs meant higher profits. It was a straightforward equation, a classic corporate maneuver designed to bolster the bottom line. But this equation had a hidden variable: the health and safety of vulnerable nursing home residents. The sums involved were not trivial. We're talking about premium dividend payments. We're talking about shared savings. These programs, running for at least the past 7 years, dangled substantial financial carrots in front of nursing home operators. For a typical mid-sized facility, these bonuses could amount to hundreds of thousands of dollars annually. This kind of money could make a huge difference to a nursing home's budget. It could mean new equipment or staff raises, or simply staying afloat in a challenging industry. The temptation was immense. The pressure, both explicit and implicit, to earn these bonuses by reducing hospital transfers became a powerful force within these institutions, subtly reshaping care decisions. The revelation of these secret payments has sent shockwaves through the healthcare industry and among families with loved ones in long-term care. It paints a disturbing picture of a system where financial incentives might override medical judgment. Residents and their families were largely kept in the dark. They were unaware that the decision to send their frail elderly parent or grandparent to the hospital could be influenced by a confidential bonus scheme. They trusted that medical needs would dictate care, not a corporation's desire to save a few $1,000,000. This trust, it now appears, may have been tragically misplaced, a casualty of a system prioritizing profit over patient well-being. The news broke with the force of an exposé, drawing on a treasure trove of confidential records and brave whistleblower declarations. These weren't just allegations plucked from thin air. They were backed by internal documents, court files, and harrowing interviews with over 20 current and former employees. These individuals, often at great personal risk, decided that the truth needed to come out. They described a culture where cost-cutting was king, and where the well-being of some of the most vulnerable members of society was sometimes a secondary consideration. The carefully constructed facade of patient-centered care began to crumble, revealing a more cynical reality beneath. UnitedHealth's strategy was ambitious and far-reaching. The company didn't just offer bonuses, it embedded its own medical teams directly into nearly 2,000 nursing homes across the country. This program covered over 55,000 long-term residents, all of whom were enrolled in UnitedHealth's Medicare Advantage plans. On the surface, this might have seemed like a positive development. Having dedicated medical personnel on site could, in theory, lead to quicker interventions and more personalized care. UnitedHealth certainly framed it that way, touting improved health outcomes and more efficient service delivery. The company argued it was about providing the right care, in the right place, at the right time. However, the underlying objective, as revealed by internal documents and whistleblower accounts, was starkly financial. The primary mission of these embedded UnitedHealth teams was to aggressively manage and reduce healthcare expenditures, particularly the high costs associated with hospital admissions. Every hospital stay represented a significant expense for UnitedHealth. By preventing these transfers, even if medically warranted, the company could achieve substantial savings. This cost-cutting imperative became the driving force behind the program, influencing treatment protocols and the day-to-day decisions made by the on-site UnitedHealth staff. The system was designed to make hospitalization a last resort, sometimes to a dangerous extent. The program was meticulously structured. UnitedHealth supervisors would reportedly assign their on-site teams budgets for hospital admissions. Think about that, a budget for how many sick elderly people could be sent to a hospital. This transformed medical decisions into financial targets. Exceeding the budget could lead to scrutiny and pressure. Staying within it, or better yet, below it, was a mark of success. This created a powerful disincentive to hospitalize, even when a nursing home's own staff or an independent physician might have deemed it necessary. The UnitedHealth personnel became gatekeepers, their primary loyalty often appearing to be to the corporation's financial targets rather than solely to the patient's immediate medical needs. Furthermore, the structure of these Medicare Advantage plans, specifically the Institutional Special Needs Plans, ISNPs, played a crucial role. Nursing homes were given even larger incentives to enroll their residents in these UnitedHealth ISNPs. This created a situation ripe for potential conflicts of interest and questionable enrollment practices. The more residents a nursing home had under UnitedHealth's ISNP umbrella, the more deeply entrenched the cost-cutting mechanisms became. It was a comprehensive system designed from top to bottom to control expenses, with the reduction of hospital transfers as its central pillar. The human cost of this system is only now beginning to be fully understood. The curtain was pulled back on UnitedHealth's practices thanks to a convergence of damning evidence. Thousands of pages of confidential company records surfaced, laying bare the internal workings of the bonus programs and the intense focus on reducing hospitalizations. These weren't vague policy documents, they were detailed operational plans, financial spreadsheets, and internal communications that painted an undeniable picture. The records showed how performance was measured, how bonuses were calculated, and how pressure was applied to achieve corporate financial goals. They provided a roadmap to a system where patient care could be compromised for profit, a stark contrast to the public image UnitedHealth projected. Adding powerful human voices to the cold data were the declarations of whistleblowers. Two such declarations were submitted to the United States Congress in May 2025, facilitated by Whistleblower Aid. These weren't disgruntled employees with minor grievances. These were individuals with first-hand knowledge of the system, deeply troubled by what they had witnessed. Maxwell Ollivant, a former UnitedHealth nurse practitioner, was one of them. He had previously filed a lawsuit in 2023, accusing UnitedHealth of violating the False Claims Act by withholding necessary medical services from patients. Although the Department of Justice declined to intervene in his initial suit, prompting him to drop it, his concerns clearly remained profound. Ollivant's congressional declaration was a plea for accountability. He detailed how UnitedHealth's programs, in his experience, led to patients not receiving the care they desperately needed. He wasn't alone. Another current UnitedHealth nurse practitioner, choosing to remain anonymous for fear of reprisal, filed a separate complaint with Congress. This individual stated that incidents of patient harm resulting from these practices were systematically hidden, downplayed, and minimized within the company. This painted a picture of an organization actively trying to conceal the negative consequences of its cost-cutting measures, creating a culture of silence and fear that discouraged speaking out against harmful practices. The combined weight of these confidential records, public filings, court documents, and over 20 interviews with current and former employees creates an overwhelming body of evidence. These sources corroborate each other, weaving a consistent narrative of a company prioritizing financial targets over the immediate health needs of vulnerable nursing home residents. The whistleblowers, in particular, provide a moral compass, highlighting the ethical dilemmas faced by healthcare professionals caught between their duty to patients and the pressures exerted by their employer. Their courage in stepping forward has been instrumental in bringing these disturbing practices into the public domain. At the heart of UnitedHealth's bonus system was a simple yet incredibly powerful metric: admits per thousand, APK. This number represented the rate at which residents covered by UnitedHealth's Medicare Advantage plans were admitted to hospitals from a particular nursing home. A low APK was the golden ticket. It meant the nursing home was successfully keeping residents out of the hospital, thereby saving UnitedHealth money. Nursing homes that achieved a low APK qualified for those lucrative bonuses. Conversely, a high APK meant no bonus, and potentially even financial clawbacks under programs like the Quality and Shared Risk Initiative, which penalized facilities for higher medical spending. The significance of APK cannot be overstated. According to one former UnitedHealth executive who spoke on condition of anonymity, APK drove everything. This single metric became the central focus, the ultimate measure of success for both the nursing homes and the embedded UnitedHealth teams. Treatment plans, staffing decisions, and even the interpretation of symptoms could be subtly, or not so subtly, influenced by the relentless pressure to keep the APK low. It created an environment where the default response to a resident's declining condition might shift from, "Should we hospitalize?" to "Can we avoid hospitalization and still manage this in-house, thus protecting our APK?" This obsession with APK had a chilling effect on medical decision-making. Facility nurses, often the first to notice a resident's worsening condition, found themselves in a difficult position. Their clinical judgment might scream hospital, but they knew that initiating a transfer could negatively impact the facility's APK and, by extension, its financial standing with UnitedHealth. As one current UnitedHealth nurse practitioner candidly admitted, "A lot of times the nurses want to send people out and we have to go in and try to stop it. And if we don't, it's on us." This reveals a direct conflict between the desire of facility staff to act in a patient's best interest and the pressure from UnitedHealth to avoid hospital admissions. The financial incentives tied to APK were substantial. The premium dividend and shared savings payments, which could total hundreds of thousands of dollars annually for a mid-sized nursing home, created a powerful motivation to align with UnitedHealth's cost-cutting agenda. The quality and shared risk program added another layer of pressure, introducing the threat of financial penalties if medical spending including hospitalizations was deemed too high. This dual system of rewards and punishments effectively steered nursing homes towards a model of care that prioritized avoiding hospital transfers, sometimes, as emerging cases suggest, at a terrible human cost. The focus shifted from patient outcome to metric achievement. Section 5, Code Red, Delayed Response, Washington State Nightmares. The state of Washington became a focal point for understanding the real-world consequences of UnitedHealth's policies. In 2019, in Renton, a nursing home resident began exhibiting clear stroke symptoms. The resident had slurred words and was unable to move an arm, classic warning signs demanding immediate emergency medical attention. However, instead of an urgent transfer to a hospital, a different protocol kicked in. A remote UnitedHealth employee, not physically present with the patient, was consulted. This employee suggested the resident might be experiencing a transient ischemic attack, a mini stroke, and advised a blood test and an update in 4 hours. Crucially, the patient's own independent doctor was not informed at this critical juncture. This delay, dictated by UnitedHealth's process, represented precious time lost. In cases of stroke, rapid intervention is paramount to minimizing brain damage and improving chances of recovery. Waiting hours for an update after a blood test, based on a remote assessment, instead of immediate emergency evaluation, is a gamble with a patient's life and future quality of life. The emphasis appeared to be on managing the situation in-house, thereby avoiding a hospital admission that would negatively impact the facility's APK. The resident's immediate medical needs seemed to take a back seat to procedural compliance with UnitedHealth's cost containment strategies, a deeply troubling scenario. Another distressing case emerged from Puyallup, Washington, also in 2019. Here, a resident displaying stroke symptoms experienced a significant delay in hospitalization, estimated to be about an hour. This delay was attributed directly to UnitedHealth protocols, which required the nursing home staff to wait for guidance from the company before initiating a transfer. An hour can be an eternity when brain cells are dying. The outcome for this resident was devastating and permanent, lasting verbal slurring and facial droop. These are not just abstract medical terms. They represent a profound loss of function and a diminished quality of life, potentially preventable with swifter action. These incidents in Washington state highlight a disturbing pattern. They suggest that UnitedHealth's system, designed to reduce hospitalizations, could directly interfere with timely access to critical care. The requirement to consult with UnitedHealth staff, sometimes remotely, before transferring a patient experiencing an acute medical emergency, like a stroke, introduced dangerous delays. The focus on metrics like APK and the financial incentives tied to them created an environment where the default was to question and potentially block hospital transfers, even when symptoms were alarming. The tragic outcomes for these residents serve as a stark warning about the human cost of such policies. Section 6. Beyond Stroke DNR Pressure and Reprimands for Saving Lives. The drive to reduce hospitalizations and control costs within UnitedHealth's nursing home program extended beyond just delaying care for acute conditions like strokes. Evidence indicates a disturbing pattern of UnitedHealth supervisors monitoring nursing homes for do not resuscitate and do not intubate orders. While advanced care planning is a legitimate and important part of elder care, the context here is crucial. Whistleblowers reported that UnitedHealth managers allegedly pressed their nurse practitioners to persuade Medicare Advantage members to change their code status to DNR, sometimes even when this went against the patient's clearly expressed wishes or those of their families. This raises profound ethical questions. A DNR order is a deeply personal medical decision with life or death implications. It should be made by the patient, if capable, or by their designated surrogate, based on their values and medical prognosis, free from external financial pressures. The allegation that UnitedHealth staff were incentivized or pressured to increase the number of DNR orders as a cost containment strategy is deeply troubling. Fewer resuscitations or intubations mean fewer expensive hospital stays and intensive care treatments. If these allegations are true, it represents a grotesque perversion of the principles of patient autonomy and informed consent, all in the name of saving money. The case of Donald Keep, an octogenarian with dementia in Bremerton, Washington, further illustrates the troubling decision-making process. On February 23, 2019, Mr. Keep was experiencing what nursing home staff noted as possible stroke symptoms, including increased forgetfulness and a facial droop. Instead of immediate hospitalization for a stroke workup, a remote UnitedHealth employee referred to a care plan that involved blood work and aspirin. More than 18 hours later, a comprehensive workup for a TIA was still listed as pending. This prolonged delay, for an elderly patient with dementia exhibiting neurological changes, underscores a system prioritizing protocol and in-house management over urgent specialist assessment. Perhaps one of the most shocking examples of the culture fostered by UnitedHealth's policies involved an unresponsive resident. A nursing home, acting on the alarming symptoms. The resident was drooling with a facial slant, made the independent decision to send the patient directly to the hospital. The hospital admitted the resident for a brain bleed, a life-threatening condition. Instead of commendation for their swift, life-saving action, the nursing home was reportedly reprimanded by a UnitedHealth manager for bypassing company protocol. The manager even scheduled retraining for the facility's nurses, presumably to ensure they wouldn't make the mistake of prioritizing urgent patient needs over UnitedHealth's procedures again. This sends a chilling message: adherence to corporate policy, even if detrimental to patient health, is paramount. Section 7. UnitedHealth's spin: improving outcomes or maximizing profits. Faced with these serious allegations and damning evidence, UnitedHealth Group has, predictably, mounted a defense. The company categorically denies that it ever prevented necessary hospital transfers or inappropriately pushed for changes in patients' DNR status. Instead, UnitedHealth frames its bonus payments and on-site practitioner programs as initiatives designed to prevent unnecessary and potentially dangerous hospitalizations. They argue that their partnerships with nursing homes actually improve health outcomes for residents. This is achieved, they claim, through the presence of their on-site practitioners who can provide tailored care plans and immediate attention, thus avoiding the risks and disruptions of avoidable hospital visits. UnitedHealth further asserts that the ultimate decision regarding hospitalization always rests with the resident's treating physician and the nursing home facility itself. They attempt to deflect blame by suggesting their role is merely advisory or supportive. Regarding the specific allegations made by whistleblower Maxwell Oliphant, the company stated that he lacks both the necessary data and expertise to accurately assess its programs. To bolster its position, UnitedHealth often points to high member satisfaction rates and even cited a 2019 study which, according to them, demonstrated that its nursing home program successfully reduced hospitalizations, implying this reduction was entirely beneficial and appropriate. However, this official narrative from UnitedHealth clashes sharply with the evidence presented by internal documents and the consistent testimony of numerous current and former employees. These sources indicate that UnitedHealth's tactics actively pressured facility nurses and other staff to defer crucial care decisions to UnitedHealth personnel. The statement from a current UnitedHealth nurse practitioner: "A lot of times the nurses want to send people out and we have to go in and try to stop it. And if we don't, it's on us," directly contradicts the claim that decisions rest solely with facility physicians. It illustrates the immense pressure UnitedHealth staff were under to act as gatekeepers against hospitalization. Moreover, while reducing unnecessary hospitalizations is a laudable goal, the core issue is how unnecessary is defined and by whom, especially when substantial financial incentives are in play. The specific cases of delayed care for stroke symptoms and the pressure to change DNR statuses suggest that the definition of unnecessary may have been dangerously skewed by financial considerations. The company's defense, while polished, struggles to reconcile its claims of patient-centered care with the documented experiences of those within the system and the tragic outcomes for some residents. The focus seems to be on the reduction itself rather than the appropriateness of each individual decision. Section 8. The Data Heist: Leaked Records and Coerced Enrollments. The drive to maximize enrollment in UnitedHealth's specialized Medicare Advantage plans, known as Institutional Special Needs Plans, allegedly led to other ethically dubious practices. Nursing homes weren't just incentivized to reduce hospitalizations for existing UnitedHealth members, they were also rewarded with larger sums for enrolling more of their residents into these ISNPs. This created a powerful financial motive for nursing homes to actively steer residents towards UnitedHealth's plans, sometimes it appears, through questionable means. The more residents covered by ISNPs, the greater the potential for the nursing home to benefit from the shared savings and bonus programs tied to cost reduction. Astoundingly, some nursing homes were reportedly so eager to facilitate these enrollments that they allegedly leaked confidential resident records directly to UnitedHealth sales teams. This is a serious breach of patient privacy and medical confidentiality. These records would provide sales teams with invaluable information, allowing them to target vulnerable residents and their families more effectively. A former UnitedHealth employee in Georgia admitted to obtaining such leaked resident records. This employee confessed to then backdating permission to contact forms to create a false paper trail, making it appear as though the outreach to these residents was legitimate and solicited, rather than initiated through improperly acquired private data. The consequences of these practices were felt directly by families. Near Savannah, Georgia, families complained that their loved ones, residents who lacked the cognitive ability to make informed decisions about complex insurance plans, were shifted onto UnitedHealth's Medicare Advantage plan. This occurred after a nursing home allegedly disclosed their confidential records to the insurer. This raises serious concerns about exploitation and the violation of vulnerable individuals' rights. Enrolling incapacitated individuals into new insurance plans without proper consent, driven by a nursing home's financial incentives from the insurer, is a profound betrayal of trust and a significant ethical lapse. These alleged actions, the leaking of private medical data and the targeting of cognitively impaired residents for enrollment, paint a picture of a system where the pursuit of profit could overshadow fundamental ethical obligations and legal requirements regarding patient privacy and informed consent. It suggests that the pressure to expand UnitedHealth's ISNP footprint was immense, potentially leading both the insurer and collaborating nursing homes down a path of misconduct. This aspect of the scandal reveals that the problems may not have been confined solely to decisions about hospital transfers, but extended to the very way residents were brought under UnitedHealth's financial umbrella in the first place. Section 9. The Reckoning, a Call for Justice in Elder Care. The revelations about UnitedHealth's secret bonuses and their impact on nursing home care have ignited a firestorm. This isn't just an isolated incident, it points to potentially systemic issues within the managed care industry, particularly concerning Medicare Advantage plans and the care of vulnerable elderly populations. The timing of these disclosures is also significant. They come amidst heightened public scrutiny of UnitedHealth, following the unrelated but attention-grabbing fatal shooting of one of its executives, Brian Thompson, and a separate, ongoing U.S. Department of Justice criminal investigation into potential Medicare fraud by the company. The cumulative effect is a serious blow to UnitedHealth's reputation and has immediate financial repercussions, with its shares falling nearly 7% in pre-market trading after the Guardian's report on May 21, 2025. The core of the problem lies in the inherent conflict of interest created when an insurer, whose profits increase by denying or limiting care, is also deeply involved in directing that care, especially when secret financial incentives are used to influence providers. Nursing home residents and their families were generally unaware of these confidential payments and the aggressive anti-hospitalization tactics that could directly affect their medical treatment and outcomes. This lack of transparency is unacceptable. Patients have a right to know if their caregiver's medical judgment might be swayed by undisclosed financial arrangements with an insurance company. This information is critical for informed decision-making. The brave whistleblowers, Maxwell Oliphant and his anonymous colleague, along with the numerous other current and former employees who shared their stories, have performed a vital public service. Their actions, supported by meticulous investigative journalism, have dragged these practices out of the shadows and into the harsh light of public scrutiny. It is now incumbent upon regulatory bodies, lawmakers, and the Department of Justice to conduct thorough investigations. If these allegations of prioritizing profits over patient safety, manipulating DNR orders, and misusing private data are proven, there must be significant consequences for UnitedHealth and any complicit nursing homes. Accountability is paramount. Ultimately, this scandal underscores the urgent need for greater oversight and reform in how managed care operates within nursing homes. We need stronger protections for vulnerable residents, clear rules about financial incentives to ensure they don't compromise care, and robust enforcement mechanisms. The health and dignity of our elderly citizens should never be metrics to be managed for corporate profit. The call now is for transparency in all healthcare financial arrangements, a renewed commitment to patient advocacy, and a system where the primary focus is unequivocally on providing the best possible care, not on the admits per thousand or the next bonus check. True shared savings should benefit patients, not just shareholders.